All right, thank you, Victoria. So to start off with, let's do a short introduction here. So as she mentioned, my name is Julianne. I live in Fishers with my fiance, who is a history teacher, which is perfect because I'm a history enthusiast. We also live with our 2 dogs and our 2 bunny rabbits there, and I work as a pharmacist for Community Health Network. Sorry, give me 1 second, guys. All right, there we go. So my passion for history helped develop our topic today. So today we're going to talk through the history of pharmacy as well as the path of a medication from development to dispensing and how that affects those medication costs. So to start off with, we'll start with the history of how we got to where we are here today. First, a definition before we get to the timeline. Let's discuss what a pharmacist and pharmacy are. So Webster defines a pharmacist as a person who is professionally qualified to prepare and dispense medications. Over the years, we've had many names, and even our training and our role has continued to evolve. Currently, becoming a pharmacist requires 2 to 4 years of college prerequisites and a 4-year doctorate program. Some areas, such as research, academia, and clinical pharmacy, require additional training, such as fellowship or residency, which is usually 1 to 2 years after your doctorate program. Once we have that education and training, there's several areas a pharmacist can work in. You can work in research and development, helping to write or amend laws related to pharmacy, or you can help consult with insurance companies to help them build their drug coverage formularies or what medications are going to cover and which medications they won't cover. Most people are most familiar with the dispensing pharmacist. So these are the ones that you see either in hospitals dispensing those inpatient medications to the nurses for patients, or working in retail or mail order pharmacies dispensing those medications directly to you. As a dispensing pharmacist, the pharmacist will work to fill, compound, or custom make specialized medications, as well as reviewing the new medications against your current drug list for safety concerns. The next largest area of pharmacy after dispensing is clinical pharmacy. These are pharmacists who have specialized during that residency training and work alongside your doctors or your nurses in order to help take care of patients and provide the most optimal drug regimen for you. They often have a contractual agreement with the providers where they can directly prescribe medications within their scope of practice or area of specialty directly to patients without, directly going to the doctor for a signature on that prescription. So in addition to caring for the patients, they also provide education on disease states and medications for both patients and providers. So these are just some of the common areas of pharmacy a graduate can work in. There's many, many more out there, too many to be listed on this one slide. So a more specific introduction of myself, now that we've talked about all the things a pharmacist can do, I graduated from Purdue University with my doctorate program, and from there I did a general residency with the University of Wisconsin for 1 year and a specialized residency with University of Arizona for 1 year. And my residency was in an area called ambulatory care pharmacy, which is just a fancy way that we say family medicine. After that, I came to work for Community Health Network as a clinical pharmacist in family medicine and got my board certification for ambulatory care. Again, just more of a fancy way to say board certified family medicine pharmacist. So I do a lot of help with finding the most effective and affordable treatment regimens for health conditions like diabetes or blood pressure, as well as providing services like education or smoking cessation and medication reviews. Sorry, I'm having just a little trouble switching slides, tiny buttons, so all right. What is pharmacy then, now that we understand what the pharmacist is? Pharmacy, as defined by Webster, is the art, practice, or profession of preparing, preserving, compounding, or dispensing medical drugs. It can also be the place where medications are compounded and dispensed. So early on in history, the difference between the practice of medicine and the practice of pharmacy was, there was a clear line between the two. The first known record of pharmacy is from over 4,000 years ago. In Mesopotamia, which is now known as Egypt, pharmacists recorded prescription recipes by inscribing them into tablets. These recipes included things like goat stomach, and none of them are recipes we would ever use today, but we at least have record of what they were doing back then. Egypt also differentiated the field of medicine, and pharmacy because they had priests who were healers that went out into the public, and they had healers who stayed at the sanctuary to make the medications. Even the ancient Greek differentiated the two fields. They had their Greek god of healing who designated his daughter, Hygeia, where we get the name or the word hygiene from, as the compounder of all of his remedies. So she made all of the medications that he, as the god of healing, would use. Excuse me one second. When we jump forward nearly 2,000 years in Europe, we have Holy Roman Emperor Frederick II, who actually forbid doctors from making their own medicine and specified that they had to get their medicine from pharmacists who were educated in making medication, and thereby really set the precedence of separating those two fields and those two arts. In the United States, the difference between pharmacy and medicine was established even before the country was established. Our forefather, Benjamin Franklin, was actually a pharmacist himself, and he helped to open the first hospital pharmacy in 1751 and appointed a pharmacist to run it. So he kind of set the precedent in America that we would continue with those European traditions of having pharmacists and doctors working right alongside each other. Another fun fact from the Revolutionary years, also Benedict Arnold was the son of a pharmacist. So we've got a lot of pharmacy-rich history at the beginning of our country's start. So pharmacy has continued to evolve over the last 200 years. In 1821, we opened the first of many pharmacy schools across the United States. We currently have 145 schools across all 50 states. So there's not a single state that doesn't have a school of pharmacy, and that includes Hawaii. The newest school of pharmacy actually just opened this fall 2021 for this current school year. So even now, we're still opening new schools on a pretty regular basis. In 1825, Elias Durand put the first soda fountain in his pharmacy, and that kind of set the image of pharmacy for the next 100 to 150 years of having soda fountains in the pharmacy through the 1950s. Surprisingly, we did not actually start regulating medications until the 20th century. At the dawn of the century, new laws finally required a label to accurately reflect what was in the bottle and to make accurate therapeutic statements. So no more snake oil salesmen. In fact, this was actually called the Snake Oil Salesman Act as a nickname as they tried to make medications a little more safer. They also set laws to regulate the previously uncontrolled dispensing of narcotics like opium. Before 1914, you could just buy narcotics and opium whenever, wherever you wanted. There were really no laws on max amounts, which was pretty unsafe for dosing. We also made major strides in our research and development in the pharmaceutical practice. So in the first half of the 20th century, we discovered insulin, which is important to treating diabetes. Before that, I mean, we have records of diabetes stretching back to the ancient Greeks where they called it sugar sickness. So basically 2,000, 4,000 years of not knowing how to treat diabetes until 1921. We also learned about bacteria and viruses, which led to the discovery of antibiotics and vaccines, such as penicillin and the influenza vaccine. So currently, we're going through a viral pandemic with COVID-19. The last viral pandemic was back in 1918, and at that time, they did not know that the flu was caused by a virus. They weren't really sure what caused it, bacteria, virus. They didn't have a way of differentiating those. So unfortunately, these major strides and laws were not really enough to prevent some catastrophic events, but fortunately, the United States foresaw that they were going to need more regulation as they were starting to see more development of medications and starting to have more laws for regulation. So in 1930, the Food and Drug Administration was officially formed based off of the Bureau of Chemistry, which was started just after the Civil War. And they were formed just in time for a national disaster. So a delicious blue raspberry flavored syrup was dispensed across the nation as a cough syrup. And the chemical that helped to color and flavor it, we now know as antifreeze. And this killed 107 people across the country through very slow, agonizing organ failure, and almost all of them were children. So this was the first time the FDA got involved in a recall of medications and tried to go across the country and kind of take those medications back and get them out of the customer's hands once they were identified as dangerous. Unfortunately, in most cases, they were too late. So this was a time of very minimal regulation for food, medications, cosmetics. Women were blinding themselves with unsafe mascara, a condition called J-leg, where the legs become paralyzed and curved, was afflicting people who drank unrefined alcohol in either alcoholic beverages or in cough syrups. And then we had this big sulfonilamide elixir disaster. So in 1937, it was technically not illegal to sell a toxic drug. It just wasn't considered really great for business. But in 1938, the FDA created the Federal Food, Drug, and Cosmetic Act, which required new drugs and cosmetic makeup to be tested for safety before marketing it to the general public. This still did not require prescriptions to be written for medications, nor did it require the FDA to actually approve the drug before it went out onto market, but companies could be audited and they had to show that they had records that they had tested it for safety before it went out into the market. So laws to address these missing pieces did not come until later. In 1951, the FDA defined which drugs required a doctor's oversight or a prescription, and which ones were safe to use over the counter with an average level of education. So before that, doctors wrote prescriptions, but you didn't necessarily have to have a prescription for any medication. You could just go to the pharmacy and request a medication. In 1962, the thalidomide disaster led to further laws regulating drug safety. Thalidomide was a sedative from Europe that was also showing promising results in reducing morning sickness. the U.S. had started trials to show the safety of the medication, even as news from Europe was indicating that thalidomide was resulting in severe birth defects that caused the arms and legs of the fetus or the child in the womb to underdevelop. And this resulted in what they called flipper babies. So this could affect one limb or it could affect all four limbs. And basically the child, instead of being born with arms and legs, would just kind of have a nub or a little flipper. So remember, currently the law only requires testing to show the drug was not toxic and deadly in the patient using the medication. It said nothing about in pregnancy or, for a fetus, because the fetus was not directly consuming that drug. And companies were also not required to report the results to the FDA before sending the drug out into public. So there was really no guidance on who or what the medication had to be tested on. They could, test a drug for morning sickness in men and say, well, it didn't cause any illness, so it's safe, and then send it out to be used as a drug for pregnancy. So when the FDA started hearing the reports from Europe, they realized they needed more oversight to American trials, and they passed a law requiring manufacturers to prove safety directly to the FDA before marketing or testing. And they also required that before testing in humans, they had to do non-human tests to show that the drug was safe. So this was the origin of animal testing. So thanks to all these laws regulating safety, it now takes a long time for a drug to go from an idea to an available drug in the pharmacy for you. However, it is also much safer. So first, a drug has to be discovered as a chemical entity. They then have to go through non-human trials, which can be chemical trials or animal trials. And then they have to go through trials in humans, both in healthy humans as well as humans with the condition that it's trying to treat. So, they can still test an anti-nausea medication in men, but if they're going to market it specifically for pregnant women, they have to also then eventually test it in that condition. So once it goes through all of those approvals and gets approved onto the market, even after it's on the market, we still do a lot of post-marketing surveillance and continue clinical studies for long-term safety considerations. So we're constantly still collecting data on all the drugs that are out there that have been approved by the FDA. Even your generic drugs have to go through this process. Generally, generics nowadays are actually made by the same company who makes the brand name drug because they already have the patent and the recipe, and so they just turn in all their previous information when the application for generics become available. And so nowadays there really is no difference between brand name and generic because they're usually just made by the company that made the brand name. All right, so once a medication is approved by the FDA and shipped off to the pharmacy, how does it get to you and why does it take so long at the pharmacy to get it ready for you? So to start with, your doctor has to write a prescription. We technically only need a prescription for legend or controlled substances. So legend meaning any drug that by law requires a prescription. So, any of your blood pressure medications or diabetes medications, and then controlled substances are those that have potentially addictive qualities. So that would be, your sleep medications or your pain medications, as well as many others fall into that category. It's optional for a doctor to write a prescription for medications that are over the counter because you could go to the pharmacy yourself and pick up, your allergy medication. However, many insurances will potentially cover some over-the-counter medications, but only if the doctor writes a prescription for it. So if your doctor just tells you to go take Claritin over the counter, your insurance isn't going to pay for it, but if you get them to write a prescription some insurances will pay for it if it's doctor prescribed. There are several elements that have to be included on the prescription, including the date, all of your information, your birthday, your address, your name, the drugs information, including, you know, the name, the strength, the form it's in, is it a tablet, a capsule, or a liquid, and then all of the provider's information. So this is much easier and faster to ensure that everything is included correctly now that most prescriptions are written electronically. Only certain people can actually write a prescription. Physicians are the obvious prescribers, but you also have your nurse practitioners and your physician's assistants. Specialized providers such as veterinarians or dentists can write prescriptions, but only within their scope of practice, meaning a dentist cannot prescribe your diabetes medication, and a veterinarian cannot write a prescription for a human at all, ever. But they can write anything that is indicated for an animal and appropriate use in an animal. There are also collaborative providers, such as clinical pharmacists, who can prescribe for certain disease states in partnership with the provider. So an infectious disease pharmacist working in the hospital can prescribe antibiotics directly to a patient, or a diabetes pharmacist working in family practice can prescribe those diabetes medications directly to the patient. It just depends on what their scope and specialties are considered. Most prescriptions today are rarely handwritten, which is due to evolving technology as well as evolving laws. So as of January 1st next year, we're no longer going to be able to call any controlled substances into the pharmacy with handwritten prescriptions or a phone call or a printed and signed prescription that we just send with you. Anything that's not controlled, we can still do that. However, most doctors don't keep prescription pads in their offices anymore. You know, it was always a risk if someone steals the prescription pad, they could forge a prescription in the signature. So switching to faxed and electronic prescribing is generally considered safer. One, the computer double checks everything is on there that needs to be on there and that the doses are safe. And then two, it's much harder for someone to steal and hijack an electronic prescription. However, just because they are safer and easier does not necessarily mean that they are faster. So when we fax or electronically prescribe a non-controlled substance, it usually arrives in the pharmacy within 5 to 30 minutes, but then the pharmacy still has to fill it. With a controlled substance, it can actually take up to 2 hours to arrive at the pharmacy from the time your doctor hits sign, and that's because it does have to go through special legal checks, being a controlled substance. But again, as of January 1st, that is going to be our only option for prescribing anything that is a controlled substance. So once it's at the pharmacy, a staff member, which could be a pharmacy technician, a pharmacy student, or a pharmacist, has to enter the information from the faxed or printed prescription from your doctor into the pharmacy system software in order to add it to your file and send it off to your insurance company for billing and create the label. The price of the prescription is not actually determined by the pharmacy unless you're paying for cash, but if you're using insurance, that price is actually determined by your insurance company. So if using insurance, the pharmacy staff member has to enter your insurance information into the system. Usually they only have to do this once a year or any time that your insurance changes. So usually at the beginning of the year, or if you change part of the way through the year. And then once they've put it in their system, they can send that information off to the insurance, and almost instantaneously, because it's all done through an electronic algorithm, your insurance will send a claim response. And there's usually one of three ways that this could go. Either your prescription is covered and it gives the insured price or the part that you are required to pay. It's not covered and the pharmacy either has to contact your doctor for an alternative or charge you the cash price that the pharmacy would charge anybody else for that prescription. Or your insurance could say that the prescription requires a prior authorization. So you've probably heard the pharmacy say, oh, this needs a prior auth or a PA before. And what that means is that the insurance wants to double check that your doctor definitely wants that medication. So usually this is only for expensive medications or medications that are not commonly used or that are not on your first choice formulary for your insurance, meaning the insurance has to pay more for that medication for you to use it. So what happens in a prior authorization is the insurance requires your doctor to explain why the medication is needed before they will agree to cover it. So the pharmacy has to send a notification to the doctor's office that the doctor's office has to fill out paperwork for this prior authorization, which usually takes 24 to 48 hours to complete, only because we don't have someone in our doctor's office that is specifically working on that. So they work on that as well as answering all the phone calls for refill requests and the other prescription issues that are coming into the office. But generally, we get it submitted within 24 to 48 hours of receiving that request from the pharmacy. And once it's submitted, the insurance takes 48 to 72 hours to review that paperwork and make an ultimate decision. And once they make a decision, it goes back to the two options above, where it's either covered and gives us a price of what we need to charge you at the pharmacy, or they tell us it's not covered and we convert it to the cash price and then discuss with you if that's okay or if you want us to contact your doctor for an alternative. So once the prescription receives its price, it's ready to be filled. First, before a staff member fills it, though, the pharmacist checks the label to make sure that everything was entered into the computer system correctly. And they also check for correct dosing and drug interactions and other safety concerns against the other medications on your list. And this is where using one pharmacy can be helpful, because then the pharmacist has a full picture of what you're taking. So if you are using multiple pharmacies due to trying to get the lowest cost on medications, just make sure your pharmacists know what you're taking. After the pharmacist approves the label, the staff can start filling the prescription. So after retrieving the stock bottle from the shelves, they count out every pill or measure out the liquid. And if the prescription is a controlled substance, they either have to double count it or have another staff member do a second count, depending on the company's policy. And then they attach your label to your bottle and return it to the shelves. Then it goes back to the pharmacist for another review to double check that the prescription matches the label that's on the bottle and that the label on the bottle matches what is actually in the bottle. And then they do a double check to make sure that there were no safety concerns that they missed the first time. Once it's passed through the pharmacist, it's put on the shelf to await your pickup. Usually most pharmacies keep it on the shelf for 10 to 14 days before putting it back on your file. When you arrive and give your name, the staff member will get all those prescriptions and ring them up for you. If there's something that's too expensive, you can decide there that you don't want it, but if you take it home and try to take it back, the pharmacy can't take it back due to laws because they don't technically know that nothing has been done to the prescription. So I always recommend checking over what's in your bag before you leave the pharmacy, because it is a situation where it's really difficult to be able to return things to the pharmacy on a legal and a policy basis. If you have new insurance or a copay card that they need to rebill the prescription, it essentially has to go through that process all over again. There's not really a drug coupon that just gets scanned like a coupon at a grocery store. So keep that in mind if you're going to pick up a medication and have something that you're going to give them to change or reduce your price. When ringing you up, that's when they should ask you if you would like to speak with a pharmacist, and this is your opportunity to have the pharmacist teach you about your medication, how to use your medication, and what to expect from that medication, or ask any other pharmacy-related drug questions. So let's kind of go back and talk about that billing piece a little more. Where are these drug prices coming from and why are they so expensive? This is very often a question that I get asked in the doctor's office. A lot of my job is helping find medication regimens that are cost-effective for patients. So, you know, maybe the best medication out there isn't the best medication if the patient can't afford to actually bring it home. So part of the issue is that there are currently no laws governing the cost of medications. That may change over the next few months. There is a bill going through Congress to change this. So that may help bring down cost of medications, especially for patients who are on Medicare. In general, the medication cost is decided by the drug manufacturer and your insurance, and then there is a pharmacy dispensing fee, although this is usually pretty minimal and almost always covered by your insurance. So usually that's something you would never see or know about if you're paying with insurance. And even then, when you're paying for cash, it's usually included in the price and is pretty minimal. There's several types of insurance that one could use to cover their drugs. There is the insurance provided, which we call commercial insurance, which is provided either by an employer or a marketplace, just not a government insurance, which is the other type, which is Medicare, Medicaid, or TRICARE, which is the insurance that's offered to our military active members and veterans who served for a certain time period. So today, since we are working with Senior Touchpoint, most seniors tend to be on Medicare. So I want to talk a little bit more about that Medicare drug coverage part. We did not have Medicare drug coverage until 2006, which seems like a long time ago when you think about it, but it actually, that means we've only had drug coverage for seniors for 15 years. Anyone who is over 65 or under 65 with disabilities or end-stage renal disease is eligible for Medicare coverage as long as he or she or their spouse worked for 10 years or more paying Medicare taxes. So when considering Part D, there's two ways to get it. You can get it as a standalone plan with your traditional Medicare A and B and your supplement, or you can get it with a Medicare Advantage plan, which is where one insurance company provides your A, B, and your drug coverage all in one plan, which is more similar to what people have with employer insurance or marketplace insurance. So that's often most familiar to many people going on to Medicare. No matter which way you go, there's going to be many options when it comes to how much the drug premium is, how much the drug deductible is, and how well they cover the drug. So you really can't go wrong with either plan as far as drug goes. It's just once you choose a plan, looking at the options for drug coverage. Because either way, no matter which one you choose, you're going to go through the 4 phases of drug coverage. So these 4 phases in Medicare Part D coverage determine how much your drugs cost each month. The first phase is a deductible phase, and that's where you pay the full cost until you hit your deductible. Some plans have no deductible and skip this phase entirely, and some plans have a high deductible. For 2022, the highest a deductible can be on any drug plan with Medicare is $480. Once you pass that deductible, or if your plan does not have a deductible phase, you go into what's called the initial phase. So this is where you pay a set copay or percentage of the drug's cost. Most plans currently have copays instead of percentages during this initial phase. So this would be like $35 for all brand name drugs and $10 for all generics. Once you and the insurance have spent a little over $4,000 on medications for the year, that's when you go into the donut hole or the coverage gap, if you've heard people talk about that. So this has nothing to do with like Medicare supplement and gap coverage. This is a drug coverage where Medicare supplements are for medical, not drug coverage. Once you're in the gap, you're responsible for 25% of that drug's cost, whether it's brand name or generic. And some brand name drugs can get rather pricey. If you think about it, 25% of a $500 drug is about $125 a month. And I can't really think of a brand name drug that's under $500 as a brand name drug where it's the only one out on the market. So most of your brand name drugs in Medicare are going to be expensive during this gap. So usually when you're signing up, that's something you should kind of keep in the back of your mind to prepare for. Because you're stuck in this gap paying 25% of the drug's cash price until you, not you and the insurance, but just you have spent $7,000 on drugs during the deductible, initial, and coverage gap phase for the year. If you happen to hit paying $7,000 for your medications for the year, you enter the catastrophic phase, and this is where you only pay 5% of the drug's cash price, so significantly better coverage, but it should be because you just spent $7,000 to get there. So when it comes to picking out your plan each year, there's different times you can get it. So for most people, they get it 2 months before they turn 65, or if you're older than 65 and you're still working and still getting drug coverage from your employer, you can wait until retirement, and they will allow you to sign up for Medicare up to 2 months before your retirement date. For everyone who's already on Medicare, you can sign up annually between October 15th and December 7th every year. And that new coverage that you sign up for during the open enrollment does not start until January 1st, whereas if you're signing up before your birthday or retirement, it starts on your birthday or on your retirement. So I do get people who ask me, what if I don't take meds? Do I need to get Part D? And my recommendation is if you do not have drug coverage from an employer as part of your insurance and you have no drug coverage but you're not on any meds, you still want to enroll in just the cheapest Medicare Part D plan you can find. There are penalties if you don't sign up for Medicare and then 10 years down the line get put on medications and decide that you do need drug coverage. They will actually charge you a penalty for every month that you do not have Medicare, and that penalty is charged to you for every month that you do have Medicare. So, you know, personal story, my uncle, I did not realize this, and I helped, when I graduated pharmacy school, started helping him sign up for his insurance, and he had had no drug coverage for 2 years, so that was 24 months without Medicare. So now every month that he has to pay his premium, he has to pay that penalty, which accrued over a 24-month period. So it's something that, you know, if you don't have any other drug coverage, you should get Medicare Part D if you are eligible for Part D so that you don't get that penalty. But if you're still working or you are on your spouse's insurance because your spouse is still working and that has drug coverage, that you will not get penalized for not signing up for Part D as long as you have some form of drug coverage other than, Medicare or nothing. And if you're ever unsure if your insurance coverage qualifies to keep you out of this penalty range, you can contact your insurance and they'll be able to tell you for sure. So there are several resources to help you with figuring out Medicare and drug costs. You can refer to the Medicare website or contact SHIP, which is Indiana's State Health Insurance Assistance Program. Community Health Network also has resources to help patients with their medication costs via the Community Medication Assistance Program. That program can help you sign up for programs to help lower the cost of your brand name drugs. So if you're on Medicare and you hit the donut hole and your drugs are suddenly very expensive, they may be able to help sign you up for assistance from the manufacturer of that drug. They can also help sign you up for low income subsidy, which is the Medicare Drug Assistance Program for people who are lower income, or Medicaid, which is the state assistance program if you are lower income. So the Medication Assistance Program team can help you sign up for those if you qualify. And then you can also ask your community doctor for a referral to the Community Assistance Program if you think any of these things are something you would need assistance with. That's something any primary care doctor within community or even any specialist within community can send you a referral for them. And then the other thing we have at Community Health Network is our Medicare Part D sessions. So let me get the next slide. So these Medicare Part D sessions happen between October 15th and December 7th each year for open enrollment. And this is a one-on-one virtual appointment to help guide you through that Medicare website. What we do as the pharmacist is we help review your medications and show you what Medicare says are the drug plans that are available to you and what Medicare says would be your cost for those drugs if you signed up for that Medicare plan for next year. So this can be an informational only session if you're just wanting to collect information, or if you're wanting us to help you enroll, we can help you walk you through that enrollment process. We don't work for any insurance company, so there's no kickback, so it doesn't matter to us if you want our help to enroll or if you just want information. We just want to make sure you have the best plan to help you afford your drugs for the following year. So I've listed the remaining help sessions for this year on this slide. There's 4 more for this year. And you can call that 317-621-1861 to reserve an appointment for one of those dates. Or if you strongly prefer an in-person appointment, or you are signing up for Medicare during a non-open enrollment period, so if you're retiring or turning 65, you can ask your primary care doctor to speak with the family practice pharmacist in your doctor's office. So within Community Health Network, we have a pharmacist who, if they are not in that clinic, we at least have a pharmacist who covers that clinic. And so we can get you a one-on-one face-to-face appointment with a pharmacist. You would just have to ask your primary care doctor to help you get in touch with them or to put in a referral for them. So that was a lot of information today. I tried to keep an eye on the Q&A and I didn't see any questions, but does anyone have any questions now that we are at the end of the presentation on anything to do with, the history of medications, or how your prescriptions work at the pharmacy, or how Medicare drug coverage works?
But we just want to thank everyone for signing in today and appreciate your time today, Julianne, as well.
Yes, of course.